вечора, good evening for everyone, and welcome all our participants from Ukraine. Sorry for a little bit late. I really hope you and your family are safe today in Ukraine. Thanks to each of you who actively participate in our course, Principles of Surgery, and today's topic is skin grafts, flaps, and management of scars. And it's a great honor for me to present our expert, Dr. Karanetz. Dr. Irena Karanetz is a board-certified fellowship-trained plastic surgeon who practiced in New York. She completed a 6-year integrated plastic surgery residency program in New York, followed by a 1-year fellowship specializing in the cosmetic and reconstructive microsurgical procedures of the breast. I must also know that Dr. Karanetz is a member of the medical mission in Ukraine of the reconstructive surgery for our soldiers. And let's start, Dr. Karanetz. You're welcome. Thank you for joining us.
Дякую, Соломія. Доброго дня, доброго вечора всім. Моя презентація буде по-англійськи, бо мені так простіше, але також трішки про себе, що я пластична хірургиня тут у Нью-Йорку, родом я з Львівщини, але я вже тут в Америці, США здобувала всю свою освіту і резидентуру по пластичній хірургії. І так як Соломія розповідала, нам всім тут зовсім не байдуже на рахунок України, і те, що скільки так само різних багато понівечених облич в зв'язку з війною в цивільних і воєнних наших пацієнтів. І минулого березня я їздила з командою американських і канадських хірургів, ми робили реконструкції цілий тиждень в Івано-Франківську. І зараз я повертаюся знову в квітні з тою ж самою командою далі проводити ці реконструктивні операції. Так що, і тому, коли Соломія і доктор Мельничук до мене запиталися, чи я, звичайно, буду рада дати лекцію, це для мене велика honor з вами сьогодні так само в віртуальному форматі це зробити, поділитися своїм досвідом. Це така дуже загальна тема мені дали, і ми можемо потім ще в майбутньому якісь ще інші такі детальніші лекції робити, але в загальному це такий буде general overview, багато різних фотографій, графічних ілюстрацій на рахунок skin grafts, flaps and management of scars. Так що тоді поїхали. Again, Dr. Karanetz, so happy to be here today to discuss the topic listed on the screen. I have no financial disclosures. And again, for anyone interested in plastic surgery who wants to learn more about reconstructive procedures, cosmetic procedures, these two books are excellent resources for anyone. There are PDF files online, and they just have great illustrations. So one is Greb and Smith plastic surgery, another one is Baker, which is very good for reconstructions of the face. So those are two great resources that I even use to this day. So in plastic surgery, the concept of the reconstructive ladder is very important. And everyone who's doing reconstructive surgeries should be familiar with it. And so what it means is that for any problem, any wound, there is a ladder of reconstruction in terms of increasing complexity. So any wound, sometimes small wounds can be treated by healing on its own, which is on the bottom here, it's a secondary intention. What we're most familiar with, and I know a lot of you are surgeons, is when the wounds heal by primary intention or stitches. That's what we do. And then what we would discuss for lots of technical difficulties, вибачайте. So going back to the reconstructive ladder, again, we start with the simplest, where the wound can heal by secondary intention, and it can be with small wounds. It can be a good management for that wound. Then we move up to primary intention, which is the way when we think about the surgical wounds, when we do the stitches, that's called primary intention. And then as we move up in that reconstructive ladder, more complex ways to reconstruct. So skin grafts, local flaps, tissue expansion, and then at the top of the ladder, the very complex surgeries that you guys may know of is free tissue transfer or microvascular surgery. But again, it doesn't mean that you always have to start with at the bottom of the ladder. Some patients, and I've seen that in our Ukrainian patients, they have very complex problems. So you do have to use more complex flaps and local flaps and grafts to do their reconstruction. But this is just a simplified method. So again, so what's healing by secondary intention? Again, this is a more of a larger wound that was managed that way. But again, wounds can heal on their own, especially if the patient, you know, has good nutrition, you know, not a smoker, and you debride the wound, you clean that wound, you debride it, and you do a local wound care. This is over a course of 2 months, but even that big wound can't heal. Again, this may not be an option if, let's say, we have critical structures exposed, such as cartilage, bone. We may have them to use more, you know, more other tools for reconstruction. But again, small wounds, even on the face, you can let them heal by secondary intention, just by keeping it clean, maybe putting a little bit of antibiotic cream, and then the wound will shrink. So that's healing by secondary intention. So again, what's healing by primary intention? That's when we think of our surgical wounds that are created by the scalpel incision. Again, it's a clean cut, and the wound edges are approximated, so they have a very good healing potential. And of course, it will heal much faster than that wound where the edges are not touching, than the secondary intention. So, and any wound healing happens in stages, as you guys may know. And typically we talk about 4 stages of wound healing: hemostasis, inflammation, proliferation, and remodeling. So number 1, hemostasis, is when you have a fresh cut or fresh injury. There, as we know, hemostasis happens and there is a clot formation. That's in any kind of injury. And then there is fibrin that stabilizes it. Then there is inflammatory and proliferative stages that then happen later. And what's important for us, since we're talking about scar management too, that the healing takes a full year. So, you know, I tell all my patients, I do surgeries almost every day. I just saw a lot of patients at the office now that they still have fresh scars. So it's important to tell your patients that at the beginning, the scar may look red, it may look, you know, like pink and raised, but it will get better over time. It would get flatter and softer, and we'll talk about scar management, which is important. But the way the scar looks at 2 weeks is not how it's going to look in 1 year. So it's important to tell your patients that it will get better, it will get softer, and there are ways we can help the body heal. Again, as long as the patient is healthy in general. So again, typical surgical wound primary closure, right? Somebody comes in, has a lesion. We usually would remove it as an ellipse. And again, this is the stitching, right? That there are many ways we can do the suturing, and I'll talk about that. And ideally, again, whenever you make any incision on the body, you want to try to do it parallel to the skin lines. So that way, when the patient moves, it doesn't pull the wound apart. So you want to make it like in the natural creases, in the natural folds. So then it becomes a nice natural line. And we'll talk about that a little more. So in this case, you can see they did a subcuticular where the stitch is underneath the skin, and then it will get removed usually a week later. So again, suturing techniques are very important. And the goal of the barodermal sutures, and I'm actually curious at the end, we can talk about it, how our Ukrainian doctors do it, but us in plastic surgery, we always close a wound in layers. And what that means is that if you're able to do those deeper stitches, and I'll demonstrate in the next slide. Yeah, if we're able to do the deeper stitches, then the stitches on the skin, the superficial stitches, can be removed much sooner, and then the wound doesn't dehisce. So again, typically we would close the wound in not just one layer. We would have some buried deep stitches and then more superficial ones. What's also important is that the wound edges have to be lined up. Obviously, if it's trauma, or again, I've seen in trauma patients here, in our Ukrainian patients, you do your best in trauma setting, and sometimes, not sometimes, and then you can revise the scar later. Usually a year later, you can try to make the scar better. But this is, we're talking, if you're making a fresh cut, it's very important that the wound edges are lined up very well, because that's how you're going to get a nice scar at the end. So you want to have good opposition. Again, you don't want to make the sutures too tight or too loose. So if the sutures or stitches are too tight, it can constrict the tissues, and then the blood flow can be compromised. It may not look good. And again, if you don't make it tight and it's loose, the wound can open up and fall apart. So there has to be a good amount of tension that would lead to a good scar. And again, every scar, whether it's surgical or traumatic, when you're stitching, it's always good to have the wound edges a little raised. You want to have the edges a little everted, because all the scars contract. And when the scars contract, that scar will flatten. So you don't want to have that kind of sunken in scar appearance. So it's good to have elevated edges. And then usually after stitching, what we would do to reinforce it, there is special surgical glue that we use, or we use steri strips, which are like little white bandages, and they can help reinforce the repair. And if you guys have any questions along the way, please feel free to ask me. So I wanted to just kind of focus a little bit on that deep stitch technique. Again, we call it deep dermal. And you see my arrow, Tak? Can you guys see? Okay. Yeah, so again, if this is our skin, superficial skin, dermis, and fat, it's in this deeper layer. It's buried, so the knot is on the bottom. And you see it's lining everything up nicely. And that means when you do the superficial stitching here on the surface, then now you have the strength of this buried stitch below, and then you can remove this one much early. Sometimes you can remove these stitches even at 5 days, but because you have these deep stitches, you're not going to worry that the wound will open up. So again, whenever I work also with students, with residents, this is the stitch that I tell that everyone should master. If you're doing a lot of stitches, you want to have good result, you don't want to have wound opening up or dehiscences, deep dermals are a very important stitch to learn. And then once we move more closer to the skin, right, then we're talking about more superficial stitches, which you guys, I'm sure, are familiar with. And again, here on the left, that's just a simple interrupted stitch. The second one, we call it running, where it's just you run along the incision. And sometimes I'll use this stitch, the last one. The third is known as a mattress suture, we call it. And it helps bring up the wound edges to make them more everted. And I'll use it often like in an extremity, in the leg or in the arm, and it's a little stronger. So again, this is now more superficial. Once you've done the deep stitches, now we're talking about the superficial stitches. And here the demonstrated ones are usually the nylon sutures, like they can be black or blue. I'm sure there is a version in Ukraine. For the face, we'll use a smaller suture, smaller size suture, because again, we don't want to leave the marks on the face especially. And we'll discuss when you should remove the stitches so that it doesn't leave those marks on the face. And again, intracuticular is the most common stitch we do in plastic surgery. right? So now, because that gives you the nicest scar usually. So again, we've done the deep stitches here, and now it's subcuticular, so it's just underneath the skin. And sometimes we'll leave the stitches out and they'll be trimmed. But this is again an example of the intracuticular stitch, which again is also a very important stitch for longer incisions. Usually on the face, I would use a lot of that other kind, either interrupted or running, but this is for longer incisions. I'll use this often in the abdomen, on the breast surgery, any long scars. And again, for this stitch, it's a dissolving suture usually. That's what we would use, so you don't have to remove the stitch after this subcuticular. So again, when do you remove these permanent stitches, right? The nylons or the prolines, not to leave those marks. Sometimes it can look like a railroad track. Like рейси трамвая, I guess. Як це пояснити правильно? Але it's important to, you know, especially if you've done the deep stitches, you know, you can remove the superficial stitches soon. So again, on the face, the stitches should be removed ideally at, you know, the longest a week. And the face heals really, really well. Again, as long as patient is not a smoker and doesn't have diabetes, but typically I would remove sutures on the face in 5 to 7 days, unless it's dissolving kind and I don't have to remove it. If you have in the scalp, in the head stitches or staples, I'll usually keep them for 10 days, 10 to 14 days. And again, very important, and the parts of the body that there is a lot of motion, the legs, the arms, the trunk, those can come apart because with all the movement and shearing. So it's important to keep those stitches for at least 2 weeks. Sometimes I'll even keep them for 3 weeks. But again, face is the least. And then the other areas, if you need more strength, I would leave it for longer. Also, let's say if I am revising a scar or redoing a scar, I would leave the stitches sometimes for a little longer because I'm redoing it. And I like this slide because I think it just shows the difference between, again, the primary intention where you have a clean cut and then it just should heal nicely with a thin line of a scar, versus secondary intention, like one of those first slides I showed where it's a big wound, the edges are gaping, and it's going to take a while for it to shrink, and it's not going to look the prettiest, but some wounds heal that way and it can save a patient another operation. So I would often talk to the patient and, you know, before redoing the scar, if they are okay with it, then it's fine. It's just cosmetically speaking, you know, if a straight line of a, you know, straight line cut with the scalpel and nice stitching gives much nicer result. All right, so in terms of healing, there are a couple of things that are important that are going to make that scar look really, really nice. And it's the local factors that affect the wound. So, you know, if there is good supply, let's say the wound is on the leg, on the lower leg, but the patient is diabetic and maybe has peripheral vascular disease and venous stasis, that wound is going to take much longer to heal than maybe a same size wound on the face on a patient that doesn't have any problems at all, right? So the tissue where the wound is and the location is important. How, you know, how good is the blood supply? Is there an infection? Like that wound that I showed at the beginning, if there is contamination, does it have to be debrided? You know, the wound has to be clean for it to heal well. And again, what we know is that smoking, radiation, diabetes are all bad for wound healing. It's just how body works. It takes much longer to heal. So I'm very honest with my patients, and I tell them, especially lower leg, those wounds can take a really long time to heal. Again, if somebody is older, it's going to take them longer to heal than a young child, just genetics. If somebody has nutritional deficiencies, such as vitamin C is important for wound healing, it can also take them longer to heal. And again, smoking, and we saw that a lot. I mean, I see that a lot in New York, of course, but I saw that a lot in our Ukrainian patients, and it really limits big surgeries that we can do. So for you guys, I'm not sure how much stress of that is in Ukraine, but in America, I would cancel surgery if patient is smoking, because I'm doing elective cosmetic surgery, and it's a much, much higher risk for healing. And if patient is paying money to do surgery, I don't want them to have healing complications. I would tell them, typically, I would cancel, and I would tell them you have to stop smoking 4 weeks before surgery and 4 weeks after. Otherwise, they have to accept the risk that their wound, I can make a pretty scar, make it as beautiful as possible, but if they're smoking before and after surgery, it's just gonna not heal the same way. So very important, and you just have to talk to patients about that. So now that we talk about secondary healing and primary healing, let's move to skin grafts. So when do we use skin graft? Skin graft we use when we can't close the wound with just stitching, if it's a large defect and we need to cover the wound. And in many cases, skin grafts still do give you a good cosmetic result sometimes, and I'll show you some pictures. Sometimes it can look more like a patch, but again, it's still a very good option. The thing about skin grafts to know, obviously, skin graft doesn't have a blood supply, right? We remove the skin from one part and we put it on somewhere else. So that skin graft is really relying on the wound bed where I'm putting the skin graft is very important. That recipient site, how well it's going to take, how well it's going to adhere and incorporate. It's not a very difficult procedure. Again, we do it all. It's I would say less difficult than some of the flaps that we're going to discuss. But still important to know how to do it well, and how do you treat the site. We call it the donor site, which is where I'm taking the skin from. So for example, often for burn patients, right, they have a big surface area. We'll take skin from the thighs and put it, let's say, on their chest where the burn is, but then it's important to know how do you manage the thigh, how to make the thigh heal well. So that's called the donor site. And then the difference between skin graft and a flap, which I learned in Ukrainian is called klapon, from my trip, is that the flaps, they have blood supply attached. So again, skin graft, no blood supply. Flap, by definition, has to have blood flow. So that's the big difference. And some patients, some doctors I've talked to in Ukraine, they were almost using it interchangeably, but it's two different things. And I just wanted to clarify that. Again, so with the skin grafts, I would say there are three main types. One is split thickness skin graft. The other one is full thickness. And then there is a composite graft, which we'll talk about it a little later. So this picture, I think, demonstrated nicely, okay? So split thickness, where I'm taking just part of the dermis, not the full dermis. And what happens with that, you can see there are these hair follicles and glands that still remain, and that's how the skin can still grow back. With split thickness skin grafts, the skin around, from where I'm taking the skin, it will grow back and reepithelialize. Full thickness skin graft is I'm taking the whole dermis and epidermis. And then I have to stitch the wound closed because now I've taken the whole layer of skin. And again, composite graft, which we'll talk a little later about, is where I'm not just taking skin, but I'm taking skin and something else. Usually it's skin and cartilage. For example, I'll do that. I'll take skin and cartilage from the ear and transplant it to the nose to do the reconstruction of the small areas where you need skin and cartilage on the nose. again, just basics that skin grafts, they go through stages of healing because, again, we're taking this dead piece of skin that then is transplanted, has no blood supply, and then it relies on the blood supply of where you're putting it to take, how well it is perfused, and how if there's good nutrients for that skin graft to take. So again, the main stages of wound healing are imbibition, inescalation, and revascularization. And that last stage is where pretty much that skin graft is now incorporated. And I'll show you pictures of the progression. But again, it's important to tell our patients that it takes time. It takes time for the skin to look, that skin graft to look better, because the body can take weeks to heal it fully. So split thickness skin graft. So I actually have a question. Do we have these dermatome devices in Ukraine? Використовують ці такі dermatome devices для split thickness skin graft?
Так.
Yes.
Okay,
Yes.
so good. So then you guys know. So again, that's the standard one we use here. It's called the Zimmer dermatome. В основному my brain is like switching between two languages. So we would mark the area to be harvested and then harvest the skin. Again, split thickness skin graft, usually we use it for larger wounds. It has epidermis and part of the dermis, like in that previous picture. As you guys know, you can choose the thickness. In America, it's usually in inches. The thickness, it could be like 16, 12 thousandths of an inch, but ultimately translates to millimeters. That's how I think about it. So again, the thinner the graft, the better it may take, because it's just like less dermis on it. And again, for burns, especially or very large wounds, we would mash the graft. Так само є в Україні mashing to increase the surface, like where you put the holes.
Yeah.
Okay, super. We didn't do any skin grafts on the mission trip, so I didn't know we did more complex surgeries. Okay, so mashing, again, I'll do it if I have a large wound on the leg, on the chest, I'll mash it to cover better the surface area. Again, where do we take the skin from, right? It's very important, especially if you have a woman, you want to try to hide that scar, right? So we'll usually do like from a thigh area, but like higher up so they can cover in shorts. You can take the split thickness skin graft from the buttocks, from the trunk. And again, you don't need to stitch where you take it from. It heals on its own by epithelialization. And then where you put it, you know, you have to anchor it. So again, this is pretty much what I would do standard when I have a wound. First, I would measure it, the dimensions, and then I would mark how much I need, because right, ideally you do that harvest once so that minimize the scarring for the patient. So I would always measure the wound, measure on the thigh, then harvest the graft, mash it if needed. This one is meshed, and then suture it in place. Typically, I don't want to remove the stitches, so I wouldn't put non-dissolving stitches or staples. If I can suture it with dissolving stitches, that's what I would do. So, and then of course we'll talk about how you make that skin graft stay. All right, the bolster dressing. So again, this is split thickness skin graft that was used to reconstruct this large lesion. And I like this picture because for those of you who are maybe new to doing the skin grafts, again, it takes a while for it to mature and look better. So just what a difference. This is the skin graft at week 1, at 1 month and 1 year, right? Big difference. So again, we have to walk our patients through that process and tell them it will get better, it will get more dry as the skin incorporates better and revascularizes. So now talking about full thickness skin grafts. So where do we use those? Typically, I'll use the full thickness skin graft for the face or for hand wounds. again, the difference is that we have epithelium and full thickness of dermis. And you can't take too much of full thickness skin graft because you have to stitch the wounds together, right? So the donor site is limited, but we'll talk where you can take it from. The good thing about it, though, is because you're stitching the donor site together, you don't need to take care of the donor site like with split thickness skin graft, that it can take weeks for it to heal, right? If I'm stitching it, I know it's covered. So I like it. If I can do full thickness skin graft for small wounds, I think it's much easier on a patient. But of course, we can't do it for everyone because some patients have large wounds and we have to use split thickness skin graft. The area that we like to use, especially for the face, you want to kind of replace like with like. So the face gets similar, like more similar sun exposure than, let's say, your chest. So if you were to take the skin from in front of the ear or behind the ear, it would match the face color much better than, let's say, if you take it somewhere else, like on your hand, on your forearm. We'll usually use, again, the skin around the ear because I can stitch it well and hide it. Around your clavicles here, you can take the skin. In your groin is very common for skin grafts, for full thickness skin grafts, and in your forearm. And because you have all that dermis as part of your full thickness skin graft, there is less contracture over time. So that's just important to know that, again, split thickness skin graft, they will shrink or contract more than full thickness skin grafts. And again, this is just a nice picture, again, that for full thickness skin grafts, that's that clavicle area and around the ears. And split thickness, we can pretty much take it from a lot of other places. Again, I try to hide the scars, so we try to hide the scar as much as possible for patients, especially our younger patients. All right, so full thickness skin graft. Again, so patient has this large cheek defect. Number one, you can always do a flap. We can probably do like a big cervicofacial flap to reconstruct it. This is just for demonstration purposes. Patient had full thickness skin graft taken from her area in front of the ear, which was then stitched together correctly. And again, you see it has a little bit of that patch appearance, but again, it's one way to reconstruct that defect, is doing a full thickness skin graft. And again, it will contract less over time than the split thickness skin graft. And then the bolster dressing is the way we help our skin grafts take. So this is a standard bolster dressing that we do, where pretty much we use this yellow petroleum-based dressing. We put cotton balls with some mineral oil, and then we wrap it tight. Мені цікаво, як в Україні роблять bolster dressings? Щось подібне?
В Україні, чесно кажучи, іноді бувають складнощі. Якраз я хотів спитати, як перекласти цю пов'язочку.
Так, я закину потім в чаті. У нас називається це Zero Form Dressing. Або є також Adaptive Dressing. Вони подібні, бо вони бо шкіра тоді, та трансплантована шкіра, it doesn't stick to it. Так що воно щось таке має бути a little oily and non-sticky. Так що це yellow dressing is what we use like pretty much in every case. And then it's tight, like sewed in with stitches, so that way it really helps that graft take.
Можна уточнити, чи це така легкомазова, легка тиснуча пов'язка, так?
Так. Угу.
Але
вона така змазана, it's like, воно трошки є таке antibacterial, вона має properties, але вона таким petroleum, жирненьким змазана, так. Щоб воно не писало skin graft, так. Але воно вже продається в нас, it's like in the same package, так що I don't have to do anything, I just open it, так. І, значить, це тоді прикладається to skin graft, and then we sew it tight, so that way it stays. And that bolster should usually, I'll keep it in place for a good week. So you don't want to remove it too soon, because then that graft can come off, right? So that graft really needs help the first week. So I would never, I don't think I would ever remove it under 5 days. Sometimes I'll even keep it for 10 days. So if you're doing a bolster dressing, I would say 7 to 10 days is a safe time. And then you can remove it, and then we'll often do the same dressing after we remove it, because that skin is fragile the first the first couple of weeks after surgery. So this is a very good dressing for wounds. Actually, I just put it on the patient now at the office. Мені цікаво, якийсь є аналог, може, в Україні чогось такого.
У нас дуже багато таких пов'язок з гуманітарною допомогою поїхали. Їх багато є зараз.
Okay, good. Так що він, важливий for wounds. So it's very, very good. Again, so you'll keep it in place for 7 to 10 days. Again, the contracture, we talked about that all grafts will contract and get smaller. So even at the beginning, you can put a much bigger graft. Over a couple months, it will shrink and contract. The split thickness skin grafts, because they have less dermis, they'll contract more. In full thickness skin grafts, because we have more of the dermis, they stay flatter more. They don't contract as much. And that's why we like it for the face, right? That, ideally that whatever I'm putting on the face as a graft, it doesn't change too much. All right, so changing gears to flaps. Again, the main difference, right, what we discussed is that the flap, by definition, has blood supply with it. And flap is pretty much a tissue. It could be skin, it could be a muscle, it could be muscle and skin, but it's any tissue that's transferred from donor site to the recipient. And the blood supply is called a pedicle. And pedicle, sometimes you may see that vessel like here. Sometimes it's just random blood supply, and we'll talk about that. The good thing about flaps, especially on the face, is that you already have the same color skin, the same texture skin. So it's a very good cosmetic result than the skin graft. It's a little more complex, but better cosmetic result. And again, with flaps, sometimes they can fail. It may not work, or it may not live, and usually it's related to this blood supply issue. And we were just discussing a case where the forehead flap died, and it was a blood supply issue. So again, very, very important, and it could be related to inflow or arterial inflow, or it could be related to the venous drainage. This is just kind of the fancy terminology, but with there may be a known vessel, a known blood supply for the flap, such as forehead flap, that runs underneath that skin. Sometimes you can Doppler it. Usually in these axial flaps, it's just by anatomy. You can measure, you'll know where that, right? We all know anatomy. We know where that vessel runs, and then if you take skin on that vessel, it should live, it should work. Random flap is where there is no designated artery, but it's just kind of surrounding tissues and subdermal plexus. And then the pedicle flap or perforator flap is where we know the vessel, we dissect the vessel, and then we transplant that tissue. So forehead flap is what's known as an axial flap, right? This is where the supratrochlear artery runs. We just know, you would measure, usually it's 2.5 centimeters from midline. You can Doppler it as well. But if you stay anatomically in that line, when you raise that flap, it will have that vessel underneath it to supply it. So again, that's a powerful tool for us for nasal reconstruction, and it's based on the supratrochlear vessel. And again, with flaps, there are different subtypes. Again, local flaps is the tissue that we use right next to the wound, and then they are divided. There are different arrangement of the flaps, and I'll show in the next picture, but the flap can be advanced, it can be rotated, it can be transposed to help cover the defect. Regional flap is located a little further from the wound, and it's usually brought to the field, such, for example, latissimus muscle flap. We use latissimus muscle flap for breast reconstruction. Latissimus is in the back, but we can tunnel it through the armpit area and reconstruct the breast. So that's called regional flap. And of course, the most complex, all the way up top, that reconstructive ladder, are the free flaps. So free flap is where I'll take a flap from the leg, let's say a fibula flap, your bone and skin, and put it in the jaw, right? And we'll sew an artery and vein using microsurgical techniques. And that's a free flap, which is the most complex. So in that book, in one of my first slides, the Baker local flaps, it's great for, I hope I can share, maybe I'll find online, щоб розповсюдити той PDF file, because it's amazing. You know, it has all the drawings, all the pictures. It's very, very helpful that if you read it, and you can probably do that flap. So I'll try to see if I have a PDF file. Щоб поділитись. So again, the types of flaps is kind of the movement. So you can see the first one is an advancement flap. We call it V to Y flap. This one is more of a rotation, that this flap is rotated into the defect. And then this one is transposition. It's just fancy terminology, but again, the tissue is moving from one place, the donor site, to somewhere else, which is recipient site. Again, free flaps may be composed of muscle only. It could be muscle and skin, muscular cutaneous. It could be like skin and fascia, or bone and skin. So it just depends what we're trying to replace, because again, we're trying to replace like with like. So what's needed, that's the type of flap we'll harvest. Again, it's all about blood supply. You need to know where the blood is coming from. Make sure that that blood, you know, that vessel is preserved in order to transplant it somewhere else. So unfortunately, sometimes it happens when harvest a flap and you injure the artery or the vein, it can compromise the success of your surgery. That's why microsurgery, even in America, not everyone, I did the fellowship, so I'm more comfortable with it, but not everyone can do microsurgery, because you're dealing with these very small vessels, and you need to know how to handle them and how not to injure them, and then how to do the microsurgery. So it takes a lot of practice and experience to do these microsurgical flaps. So radial, again, we're talking about subtypes of free flaps. So radial forearm flap, where we take skin and fascia from the forearm area, is a very powerful free flap that we use a lot for head and neck, for trauma. And again, you take it with the radial artery and vein, and then it's usually then connected to the recipient artery and vein, let's say in head and neck region. And then again, a lot of it is in the markings, knowing anatomy, and typically anatomy doesn't lie. So another very good site, if you guys are interested, is called, let me start here, microsurgeon.org. Microsurgeon, like where they go into describing the free flaps. It's specifically focusing on free flaps, but if you want to read about it, it's a great resource. They have great diagrams. When I was trained with all that, and very basic, but very good. One of the more complex flap, I would say, in plastic surgery is the bone flap transplantation, which is a osteocutaneous free flap, such as fibula. Again, it's often used for jaw reconstruction, They've been doing that a lot more with the blast injuries in Ukraine for the soldiers, with when the maxilla and the mandible are destroyed. So then there is no other way. You have to bring healthy bone. So typically you'll take fibula. Fibula is a non-weight bearing bone, so you can still walk technically normally afterwards. And you can take it with skin and bone and then transplant it to reconstruct the missing pieces in the jaw. So that's just like a general overview of, flaps and skin grafts. And I just wanted to go over a little more application of these flaps and grafts, especially in the facial reconstruction, because I think everyone's interested in that as well. And I think it will make more sense that, again, when we look at the face, you want to understand the anatomy first, and then you're going to know how you're going to reconstruct it. On the face, obviously, we have important structures. We have the eyes, we have the nose, we have the mouth. So it's very important. Those are the critical structures. And then again, what I was talking about in terms of where you want to make a cut, right? If you were to remove a lesion on the face, and let's say a lesion is here, you want to make it parallel to these lines rather than across, because then these lines that exist all over the face, they will, hold on one second, let me just tell them to be a little more quiet 1 second. Thank you. Thank you. Okay. So yes, so these relaxed skin tension lines, we call it, but you can look on anyone's face, there are little lines. So whenever you make a cut, you want to try to make it parallel to these skin tension lines rather than across, because it's just not going to heal the same way. So again, with those simple elliptical incisions, you have to make it parallel to those lines. And again, since we're talking about wounds and reconstruction, like in that picture, you want to know which structures are involved. You want to estimate how much of the tissue you have missing. Is it skin only? Is it skin and cartilage? Because again, you want to, for the best cosmetic results, you want to replace like with like. So if you're missing skin on the cheek, you want to replace it with the skin somewhere nearby. Or if you have a cancer in the upper eyelid, you can borrow skin from the other upper eyelid and use it. So you're replacing like with like. And again, knowing how deep the injury is. So in terms of reconstruction of the nose, again, this is just the basic anatomy that the nose has, proximal, middle, and distal portion. And it's important to know that the skin envelope of the nose is different in the upper part of the nose versus lower. If you touch your own nose, it moves more here, but less here. And again, that dictates that skin quality is going to dictate what we can do to reconstruct the upper part of the nose versus which is more mobile versus the lower part of the nose, which is less mobile. Again, when we're talking about the nose, again, just like any wound, you want to know where exactly it's located, which subunit of the nose, if it's skin only, if it's cartilage, or if it's the lining of the nose. Whenever we talk about nasal reconstruction, it's always important that you want to make sure the patient can still breathe. And of course, try to minimize the scarring and give them a good cosmetic result. So the nose, whenever we talk about reconstruction of the nose, we break it down to the units. So there are 9 subunits of the nose, which are marked here. And one of the surgeons who described a lot of these nasal reconstruction flaps, pretty much they came up with this concept that even if you have a small defect, sometimes you may have to, but if it's more than 50% of that subunit, then you may have to remove the whole subunit to give you a nicer result. And it goes back to kind of where you would place the scars so it all blends in nicely with the subunits of the nose. Again, lining is just, it's important to reconstruct inside the nose. So since we're talking about grafts, cartilage grafts is the way we reconstruct the nose if cartilage is missing. Typically, we can take for the nose the cartilage graft from the ear, or we can take, if you need to do a lot of nasal structure reconstruction, we'll take the rib. So this is just shows a picture of the cartilage grafts, and then they can be placed inside the nose to help reconstruct the missing cartilage. Composite skin graft. I didn't talk about it much at the beginning, but again, it's when you take the skin with the cartilage, because it's still just a graft with no blood supply. You can't take this composite graft and make it big. It's not going to live. So these have to be very small defects on the nose that involve skin and cartilage. Ideally, the defect is only less than 1.5 centimeters. And then as long as it takes and it revascularizes, then it can give you a nice reconstruction. So usually if you can have a small defect on this part of the nose with skin and cartilage involved, on the alar rim, that would be a good reconstructive modality. Again, in terms of certain areas on the face, which is your glabella here, if you have a wound in this area, sometimes if it's small enough, again, less than centimeter, secondary intention, which is the wound healing on its own, can still work. If the wound is larger, then you may need to do a skin graft or flap. But again, for small wounds, sometimes you can just let it heal on its own by secondary intention. And this shows a reconstruction using full thickness skin graft. Again, there was no cartilage involved, so you can just put a small patch of skin there. If there was cartilage involved, then probably we would have taken a small piece of cartilage from the ear to complete that reconstruction. And when we talk about flaps, glabellar flap is again, it's an advancement flap, right? We're kind of advancing it from above to below, is a way to reconstruct the defects on the glabella or upper nose. This is another flap that can be used to reconstruct the nose defect on its blood supply, right? So it's an axial flap known as dorsonasal flap. And then it's advanced to reconstruct the defect. So typically when, nose is a small structure, but to really move the tissues, I actually like this middle picture a lot, because to do a successful flap and for tissue not to die, not to be too tight, you have to undermine a lot. So you can't just make a cut and think it's going to move. It's not going to move. You have to move the tissue all around, mobilize it so that then it moves, so then it advances. So very important with flaps. Again, this is where the blood supply is coming from, right? So that's that axial blood supply. So that's the only inflow, because everywhere else it's cut around it. And again, lots of mobilization. Another little local flap, more like transposition flap, where again, you can use this mobile skin of the nasal sidewall and then swing it to this defect. And remember, just a couple slides ago, I showed this reconstructed with the skin graft, just the full thickness skin graft. So again, you can do either. If you guys are starting out to do reconstruction, I would say maybe start with skin grafts, get comfortable with that, then do these local flaps, like small ones, and then do bigger flaps like a forehead flap. So you kind of have, I think I would start slow and then move on to more complex flaps. Again, a lot of it is very based on geometrical measurements and moving the tissue into the wound. And again, this is just the measurements, that how you have to do this bilobed flap and the degrees at which you make the cut. And I remember doing this when I was a much younger surgeon, and I read one of these books and I measured it the way they measured it, and it worked. So that's the good thing about plastic surgery, and I think like sharing this and then you guys reading on your own, maybe watching some videos, I do think you can do these reconstructions. You just have to prepare. And if any of you guys do any of these reconstructions, and I can share my email on WhatsApp. If you have any questions, you can I can always give my input as well. I'm more than happy to do that. Again, this is just an example of that bilobed flap. Again, fancy design. It will heal very nicely. Can you do a skin graft, full thickness skin graft? Take a little skin from in front of the ear? Sure, you can do that as well. For an older, I would say like this, for older patients, I'm more inclined to do a skin graft. If it was my nose, I would want a local flap probably, because it gives me better skin texture match. So you kind of have to gauge your patient and understand your patient, you know, do they just want the simplest thing, which I think I would do then the skin graft. Again, nasolabial flap. I actually saw some of the Ukrainian surgeons doing these as well. Again, it's based on the blood supply from nasolabial artery here. It's used for the nasal reconstruction of the side on the side of the nose. Typically, because you have cartilage here, again, you may need to harvest cartilage from the ear. And again, to close all of those wounds, you have to undermine it. So this just shows a nasolabial flap. Again, that's how it was designed, and then kind of brought into the field. And then again, this usually to close it, this wound, you have to undermine it. So I think, again, if you're considering doing flaps, you have to get comfortable with lifting the tissues and undermining with scissors so that it moves. And then you get a nicer scar, because if you do stitches and it's very tight, that scar is not going to look good. So you have to undermine it. And then here you can see the cartilage graft that they used for to reconstruct the alar rim. And then again, that was first surgery, and then in second surgery you would cut that pedicle and then contour the nose. So usually those surgeries like forehead flap, nasolabial flap, you have to tell your patient it can take two procedures sometimes to get the nicer results, sometimes 3. So again, forehead flap is a big power horse for nasal reconstruction. You can use to reconstruct the whole nose. It's based on these supratrochlear vessels. And it can cover the defect up to 3 centimeters on the nose. Again, sometimes you can design it to take even extra skin to give the lining of the nose. Like you can see here that the flap was made very long, and then part of it was turned in to do the lining. So again, that's the thing with the nose, that the nose has usually in that area typically has 3 layers. It has skin, cartilage, and lining, and you have to reconstruct all 3 layers. Again, going back to smoking, I think if you don't get that message from my lecture, I wouldn't do this flap in an active smoker. You know, you have to tell them quit for at least 2 weeks, because again, smoking causes vasoconstriction. There's going to be blood flow issues, and that flap can die. And our patient can have a big scar on their face and a dead flap. So that's not good. So again, with forehead flap, usually you would wait about 3-4 weeks. So you don't want to cut this pedicle for at least 3-4 weeks, because this has to kind of revascularize. And again, I've seen that happen where sometimes they'll cut it too soon, and again, it all can die. So again, waiting is a good thing, at least 3-4 weeks. And again, it's important with nose especially that to tell patients that you may need more surgeries to kind of fine tune it. Again, with cheek reconstruction, going back again to those lines in the face, again, that if you're cutting out a mole, and I'm sure you guys do that at the office, just pay attention that it has to go parallel to those skin lines. You don't want to go across, because then they'll have not a very nice scar. And some other fancy flaps are known as, I do like rhomboid flap. Again, all about geometrics. it's about the angles, it's about the measurements in centimeters, and it does work. You do have to do undermining as well for tissues to move. And it has a nice, diverse design. You can reconstruct a lot of wounds with it. So again, this is a cheek, right? If you put just a full thickness skin graft there on a young guy, it will be a circle, it would be a patch. So if you can design this nice rhomboid flap, and the angle is usually 60 degrees and 120, and move it into the wound, it will give them a nicer result, a nicer scar at the end. Again, often you can use the neck skin because it's a little more loose, and you can use that extra neck skin and move it up to cover the defect. This is one of my patients where, again, it was a defect after basal cell cancer excision, and that's the flap. I designed it kind of from this area, and as a video.
All right, go ahead.
I'm just showing how much tissues have to like move
Yeah.
for things
Okay,
to
so
close.
gonna come together nicely like that. Yeah.
Yeah, so again, undermining, big part when with local flaps. I had to undermine for like 2 centimeters, everything around,
All right, go ahead.
and then it comes together nicely. Again, cervical facial flap is another way to reconstruct these big defects. Again, good color and texture for the face. Again, a lot of undermining. So kind of looks crazy, but that, you know, to move that much to reconstruct this, they made a cut here and then undermined the whole cheek to then move it to reconstruct this little hole. And again, at the end, that's her result. Could you do a skin graft? Probably, but that's what they chose in this young patient. So it's a large cervical facial flap. This is one of my patients where I used the inferior skin as an advancement, and I pulled it into this hole. This was after melanoma, and again, that's the nice part, right? If I did a skin graft, it would be a patch, but the scar, and I think this is also a good example that how the scar looks at 3 weeks versus 6 months. And we'll talk about scar management because that's important. Again, very extensive undermining for the really large defects sometimes that you'll do. Tissue expansion. Does anyone use expanders in Ukraine? Використовують? Є доступ?
Так.
Okay. So obviously it's a way to stretch the skin when you have big defects for burns or for scar contracture. The best part about it is that when you stretch the skin that you really need on the face, you want to replace like with like, so we'll often stretch kind of the chin and the neck area to expand it so you have more skin, and then you move it to reconstruct the wound. So again, this is an example of tissue expander that's more like elliptical shaped. So then in terms of the scar management, so we already talked about stitching, we talked about undermining, and again, making sure it's not too tight and not too loose, and all of these things at the end should create a nice scar. And, you know, for those of you who do some cosmetic procedures, patients want to see a nice scar. So, you know, for example, here I have a lot of darker skin African American patients. They can be more prone to keloid thick scars. So I also have to know, we have to know how to manage that. But in general, again, the goal should be, and especially with elective surgery, I'm not talking about trauma, a nice thin scar. And so what do I usually tell my patients in terms of scar management? So again, the first 2 weeks, my patients are not doing much. Usually the scar is covered with those white bandages or surgical glue. Then I start all my patients on a silicone scar treatment. I do a lot of breast surgery. Sometimes I'll use this silicone tape. For anything on the face, I would use silicone scar cream. And there are studies that have shown, I mean, there are so many creams out there, but the silicone-based creams are the ones that really help the scars fade, and they hydrate the scars, they prevent the scar thickening from extra collagen formation, and they help flatten the scars. Again, usually I would start it at 2-3 weeks on the face. You can even start it early. So if I know when I was giving a lecture last year in Ukraine, I think there are some silicone scars in Ukraine too, right? On the market. Є доступ до силіконових кремів таких?
Там силіконові креми, які в нас на ринку, вони від 2000 починаються.
Вау. Бо в нас тут на Амазоні you can buy them really cheap. Ну, в загальному, може, якийсь потім буде інший варіант, але найкраще це є ці силіконові креми, особливо для обличчя. І також важливо масажувати шрами, так що пацієнтам after 2-3 weeks, I'll tell patients to start massaging the scar. Бо на початку можуть бути затвердіння, де є шрам, а рубці, потім важливо масажувати кожен день, буквально хвилину, масажувати рубці і прикладати цей scar gel. І також важливо sunscreen, because with a lot of sun, the scars can get dark. So if I was to say the 3 things most important for the scars, let's say you do good stitching, which is great, then it would be silicone cream, scar massage every day for like a minute, and then protecting from the sun. So if it's on the face, you have to put sunscreen over fresh scars because they can get darker. And again, whenever you're revising a scar, sometimes we would use these geometric broken lines, so that way the scar looks better rather than just cutting it out in a straight line. And actually, we did this in Ukraine for some of our patients with bad scars, unfortunately, from injuries. We would do this geometric design. And again, that book, Baker's, they have good descriptions. And you see how the scar again gets lighter over time. Okay, that's it.
Great. Дякую, Ірина. У нас такий мікс польсько-української мови. І дякую за лекцію. Вибачаю за якісь технічні неполадки, можливо, теж зі сторони організаторів, але я думаю, всім було цікаво. Я в захваті від лекції. Змінюю дещо в своїй практиці, тому що я не пластичний хірург. Але завжди важливо, пацієнт завжди оцінює хірурга по шраму.
Обов'язково, 100%. Так, я бачу, в нас є декілька питань, так що рада.
Так, і якщо у вас ще є кілька хвилин, було
Я маю,
вдячна.
так, і потім біжу до пацієнтів. Ага.
Якби ми могли теж просити вас зареєструватися в нашій аплікації Heal.ua, там теж наші учасники і інші учасники, якби аплікації задають запитання про своїх складних пацієнтів, і теж з пластичної хірургії, якби можна було там комунікувати, надсилати фотографії і отримувати рекомендації, то це було б чудово. Я надішлю після лекції всі деталі. А зараз зосередимось на наших запитаннях.
Так.
І, на жаль, я не бачу піднятих рук. Чи ми могли б зупинити поширення слайдів?
Так, зараз.
Супер. Олександр Боярський, прошу вас.
Дуже дякую за чудову лекцію. Моє питання: чи використовуєте ви системні препарати для тромбопрофілактики у разі використання великих якихось клаптів? І у випадку венозної конгестії та венозного тромбозу, чи використовуєте ви локальний тромболізис для вирішення цього питання?
Хороше питання, дякую. На рахунок тромбопрофілаксис, Якщо це ми говоримо такі клапті на обличчю, в основному ми не даємо ніякі такі розріджувані препарати. Якщо я роблю велику операцію free flap, це може 10-12 годин зайняти операцію, тоді так, ми даємо дозу або гепарину, але це не для клаптя, це більше для, щоб в ногах не робилися blood clots, так, і не було емболізму. Якщо є локальний проблеми чи венозні, чи артеріальні. Локально ми що використовуємо нітрогліцерин, у вас є такий подібний крем. Я часто використовую, бо в основному кінцівки цих клаптів, вони завжди, в них є недостатність, так як ви бачите на фотографіях і в досвіді. І на початку воно завжди виглядає гірше. Якщо операція правильно зроблена, через 2-3 тижні, коли циркуляція відновлюється, воно виглядає набагато краще. Але чи це є цей forehead flap, чи це є такий клапець зі щоки, в моєму досвіді і в досвіді моїх партнерів, воно завжди таке синювате з венозними проблемами. Просто треба це знати анатомічно, розуміти. Хіба що якщо воно справді щось з циркуляцією, то тоді можна дати якийсь ще аспірин чи щось таке. Але в основному ми, так як ви говорите, буде, Олександр, локальний topical, I would do nitroglycerin, в основному 2 в день, на протязі тих перших 2 тижнів. Це я так зроблю, але системно я в основному для локальних я нічого не даю.
Дякую за відповідь. І наступне запитання від Владислава Мельника.
У мене буде декілька питань, але я буду по черзі задавати.
Попрошу, давайте зосередимося по одному питанню. Попрошу вибрати, бо в нас багато піднятих рук, час
Я
обмежений.
ж кажу, по черзі.
Так,
По
так,
черзі.
так.
Якщо ви робите естетичну операцію і у вас після оперативного втручання починає з'являтися рубець, яка ваша тактика?
Мгм. Так, ну, звичайно, я всім пацієнтам кажу, завжди буде у вас рубці, так. У мене часто пацієнти думають, що я пластичний хірург, і тоді в них не буде шрамів чи рубців. Impossible. Потрібно всім казати, ціль просто наша ціль, все, щоб були хороші рубці, так? Якщо після 2 місяців, наприклад, перші 2 місяці в основному рубці так загоюються на 80%, потім може бути таке затвердіння, як гіпертрофічні, можна вколоти тоді ці стероїдні кеналог лікарства. Я знаю, це також дорого, бо я привозила з Америки на операцію. Але це вже, якщо справді такі дуже товсті рубці, тоді коли це кеналог. Важливо його так само розріджувати, бо дуже концентрований цей кеналог, воно може висвітлити шкіру і може бути побічний такий ефект навколо рубця. Так що дуже важливо, знову ж таки, якщо у когось є питання, я дам свій імейл, я можу написати свою дозу, яку я роблю. З досвіду я деколи давала забагато і було за трошки side effect. Але важливо, знову ж таки, після перших 2-3 тижнів косметичної операції почати силіконовий трітмент, якщо це справді хтось, або якийсь такий аналог чи варіант, що є в Україні, якщо хтось справді платить гроші за це, я рахую, це важливо зробити, щоб покращити, як ці рубці виглядають.
До цього ж питання. Ви коли зашиваєте рану, ви використовуєте розсмоктуючі чи не розсмоктуючі матеріали саме в дермальних шарах? Бо розсмоктуючі матеріали, вони можуть спровокувати запалення, по суті,
Так.
а не розсмоктуючи потім діставати.
Так, так. В основному я зашиваю в мінімум в 2 шарах всі операції. Ці, що розсмоктуючі нижні шари, якщо це на обличчі, це я використовую, нитка називається монокрил. Вона скоріше розходиться і не є такої багатоінфламаційної реакції, як, наприклад, вайкрил. Але в загальному я використовую обидві, просто важливо, щоб це були такі глубші шви, щоб не було такої інфламаційної реакції багато. І потім я або зроблю це нижній шар, і потім для моїх косметичних операцій в основному це такий підшкірний шов, що я роблю. Хіба що якщо мені потрібно зовнішній, то я тоді зроблю ще зовнішній з цієї чорної нитки найлон, але воно мусить бути знято на протязі 7-10 днів, бо інакше воно залишить тоді ці такі маркери від нитки, від шва.
Дякую.
Угу.
Дякую за запитання і відповідь. Ольга Іванченко, від вас наступна відповідь, будь ласка. Ми вас не чуємо. Далі не чуємо. Можливо, ви поправте собі технічні якісь аспекти, а ми попробуємо Софію Лисенко.
Добрий вечір, дякую за чудову лекцію.
Лисецька, перепрошую.
Страшно. Дякую за чудову лекцію. Моє питання теж по келоїдним рубцям. Якщо у нас є пацієнт, якого в анамнезі в дитинстві був келоїдний рубець, була ексцизія оперативно, тому що топічні креми і місцеві кортикостероїди не допомагали. І зараз уже в дорослому віці пацієнт звертається на оперативне втручання. Чи потрібно нам превентивно щось використовувати, чи враховуючи якісь меншу регенеративну здатність тканин, ми можемо просто заспокоїтись і просто спостерігати за цим?
Ці такі кілоїдні рубці – це важка проблема, бо це генетично, і я всім пацієнтам своїм кажу, що це 50% шанс, що я можу поправити. Якщо я перероблю, якщо це справді турбує пацієнта, і вони хочуть ще раз, третій раз, наприклад, переробити, це можна видалити, але потрібно ще щось, крім видалення ексцизії, так як ви говорите, зробити. Навіть під час видалення я інколи вколю трішечки розбавленого кортикостероїдного, не дуже високу дозу, бо воно тоді може вплинути, як загоїться той рубець, але якби щоб той ефект тої інфламації, щоб не повторився. І тоді я буду дуже спостерігати, знову ж таки, я почну з силіконові наклейки або крем, і якщо потрібно, якщо я бачу, що рубець через 6-8 тижнів, цей, що я перероблю, знову починає бути більш товстим, то тоді я знову вколю кортикостероїдні. Тому в нас рекомендації, ви можете мінімум 2 рази колоти, це має бути 6-8 тижнів між тими ін'єкціями, але це такий агресивний метод, щоб не повернувся кілоїдний рубець, або в нас так само роблять локальну радіацію, щоб знову ж таки той інфламаційний процес якби збити. Звичайно, якщо це десь рубець на грудях і тут серце, легені, я не рекомендую цей radiation therapy, але в мене був пацієнт, що в нього на вусі вже 3-4 рази переробляли, і коли я його переробила, я вколола...
Треба задати питання, у мене не спрацьовував цей мікрофон.
Я вколола кортикостероїдні після видалення і потім його послала ще на радіацію. Роблять в Україні радіацію для, напевно, я не знаю, для... Дуже рідко, частіше лазерна терапія. Окей. Ну так, але воно зв'язано більше... Тут є спеціальні протоколи на radiation therapy for keloid scars, але це такі... Один в мене пацієнт ходив на radiation, бо це так само час займає. Але я більше концентруюсь на видалення і потім кортикостероїдні ін'єкції 2-3 рази, якщо потрібно.
Дякую.
Дякую дуже. Ольга Іванченко, чи вам вдалося?
Ви мене чуєте, так?
Так, чуємо тепер.
Моє питання було по кілоїдним рубцям.
Ага.
Да, ви вже на нього відповіли.
На нього?
Так, але важливо так, і так само, як у вас проблема, так і у нас проблема, бо це є генетична проблема пацієнта, і просто, я думаю, я всім їм кажу, що вони мусять зрозуміти, що ми можемо переробити рубець перфекційно, ідеально, але в них просто генетичний потенціал до того, тому казати потрібно, що так, 50-50 chance, що воно може вернутись, може покращитись трішки, але це не від нас залежить. Ми попробувати можемо і з кортикостероїдними ін'єкціями переробити, так.
Дуже дякую.
Дякую за вичерпну відповідь. Ірина, чи у вас ще є час? Чи ми...
Чекайте, я йду, зараз чекайте, в медсестри запитаю, секундочку.
Жива дискусія. Таке життя. Я ще раз вам нагадаю, бо бачу дуже багато піднятих рук. Я розумію, що з такими пластичними питаннями стикаються всі хірурги загальні, дитячі, будь-якої іншої спеціальності, бо ми розрізаємо щось, зашиваємо щось. І тому це дуже актуальна тема, взагалі пластика в загальній хірургії. Я дуже наполегливо і щиро вас запрошую до HealUA, тому що я впевнена в тому, що доктор Каранець буде відповідати на наші питання, як тільки в неї буде можливість.
Я маю ще 15 хвилин, бо я достатньо дала часу в офісі. Окей, так що продовжуємо. Ага.
Great. Супер. Тоді продовжимо від людей, які ще не задавали. Доктор Тромбола, Олег?
Дуже дякую за лекцію. В мене запитання, чи ви використовуєте ін'єкції ботулотоксину для зниження динамічного натягу шкіри і профілактики гіпертрофії рубців?
Excellent question. До речі, ми якраз це робили під час моєї місії минулого березня. Бо в хлопця було так, це практикується. Звичайно, є ціна ботокса в тому, але мені здається важливо зрозуміти, де саме є рубець. Наприклад, у нас був пацієнт цивільний на місії, що в нього тут з дитинства був рубець. І тут якраз у нас багато мімічних м'язів. Тому ми, як я йому видалила рубець і все ми зашили, ми вкололи профілактично до операції. А я би сказала, якщо є доступ до ботоксу, щоб це справді не було так багато того motion, щоб все гарно зажило, я би зробила мінімум 7-10 днів до процедури, щоб ботокс мав повний ефект, і тоді видалити рубець. Але, звичайно, якщо десь в щуці, воно не має сенсу, але тут в районі upper face, це хороше. І це є так само, вони робили дослідницькі роботи, що це працює і допомагає, тому так. Good question. Тільки я би зробила 7-10 днів до.
Дуже дякую.
Супер, дякую за запитання і за відповідь. Кирил Соколов, будь ласка, ваше питання.
Доброго вечора. Дуже дякую за таку класну лекцію. Дійсно цікаво і корисно. Моє питання полягає в наступному. Коли ви робите вільні клапті, вільну шкіру пересаджуєте, чи використовуєте ви таку техніку, як утворення фібринових хустків і підкладання їх під низ, виходить, цієї вільної шкіри?
Я такого не робила. Інколи якщо це такі, як в нас є такі фібринові препарати, що воно таке, як спрей. Це є більше як фібринова така, як матеріал? Чи більше
це, виходить, з крові пацієнта утворюється фібриновий згусток і підкладається під низ. І чи стикалися ви з такою технікою, і чи можете ви сказати, наскільки це ефективна штука?
Ні, я з цим не стикалася. І, якщо чесно, я не знаю, чи би я хотіла, щоб було щось як бар'єр між клапаном і де той клапан має прижитися, бо важливо, коли клапан не має доступу до кисню, до цього всього, щоб не було, тому воно так має бути дуже прижате тим болстером. Тому ні, я це ніколи не робила, я не знайома з тим, але я навіть не знаю, чи я би це зробила, бо особливо, що якщо це є вільний клапан, як ми говоримо, skin graft звичайний, він дуже має бути прижатий туди, де ви його пришиваєте, і якщо є там кров, чи навіть рідина назбирується, то він тоді може не прижитися добре. Тому я би не рекомендувала, щоб було щось таке, як бар'єр між клаптем і де ви його пришиваєте.
Ага, я зрозумів, дякую.
Дякую за запитання. Пан доктор Ізмаїлов Георгій. Будь ласка, ваше питання.
Дякую за лекцію. Моє запитання полягає в наступному. Чи потрібно досягати абсолютного гемостазу, навіть сухості в рані? Чи це сприяє, чи навпаки зашкоджує заживленню рани? І Чи потрібно ліквідувати мертві простори, так звані, наприклад, при закритті апаратомії, чи це працює, чи ні, бо багато дискусій з того, що я читав і знаю.
Хороші. Ну, гемостаз – це важливо, але якщо ми, наприклад, якщо ми говоримо якась є там велика рана в грудей чи в області живота, наприклад, то тоді важливо зробити гемостаз. Я в основному підшкірних тканин, але сам, де є дерміс, де є те, що має зажити шрам, я стараюсь дуже багато. В нас, наприклад, використовують така electrocautery, так, що воно якби підпалює тканини. Важливо, щоб не дуже спалити самі тенди шкіри. Під шкірою так, щоб не набиралась рідина, це важливо. Але я би була дуже careful, де саме шкіра, то що ви будете зашивати. І на рахунок того dead space, так як ви говорите, в нас часто використовують дренажі, так що в нас це прийнято, наприклад, якщо я роблю якусь велику реконструкцію, я не хочу, щоб та рідина залишалася, бо це може бути сірома, потім інфекція, так що в нас практикуються часто дренажі, якщо я якусь операцію велику переробляю, і чи видаляю, чи чищу, і є багато такої кровотечі, я дуже часто залишу дренаж, тому в тому нічого немає поганого. Пацієнт не дуже це любить, але я завжди залишу, якщо я рахую, що це буде краще. І коли та рідина не назбирується, то потім менше обріку, навіть шраму буде краще так само. Так що я рахую, що це і дренаж, я не знаю, як вас, коли так само знімати дренаж важливо. Наприклад, в нас прийнято в Америці, що дренаж має бути менше, ніж документацію пацієнт має записувати, якби скільки мілілітрів, має бути менше, ніж 30 мілілітрів в день на протязі 2 днів. Тому, наприклад, як ви говорите, що це щось з животом чи лапаротомією зв'язано, то якщо, наприклад, 50-70 мл в день, я би не знімала дренаж, що насправді має бути 30-25, і тоді я знімаю дренаж, і тоді я впевнена більше, що та рідина, навіть якщо там трішки є, потім організм її зробить absorb, ніж залишати всю ту рідину, щоб вона там сиділа, якби могла якісь побічні ефекти зробити.
Дякую.
Супер, дуже цікаві запитання.
Так, добре.
Зараз попрошу доктор Червонооченко. Ваше запитання?
Дякую за лекцію. В мене теж, до речі, питання стосовно дренування підшкірної клітковини. Як ви дієте у випадках, коли, наприклад, у пацієнта доволі виражена підшкірна клітковина, є великий простір в підшкірці і стоїть дренаж. По дренажу виділень доволі багато, але там пацієнт, наприклад, випадково вирвав дренаж і він випав. Шкіра вже зажила, тобто там, скажімо, пройшло більше тижня, і шкіра вже добре зажила, і є лише дренажний отвір, звідки випав дренаж. Але по дренажу було багато виділень, і бажано було б ще його потримати. Як краще перевстановити цей дренаж при такій вираженій підшкірній клітковині?
Також хороше питання. Інколи буває, так. Моїх пацієнтів також випадають, чи вони самі забирають ті дренажі, я не знаю. Але я тільки щось роблю, якщо я відчуваю, що та рідина назбирується, так. Якщо я зроблю інспекцію тканини і відчуваю, що там назбирається рідина, тоді це не значить, що я мушу ставити знову дренаж. Інколи я просто з уколом, великою такою побільше голкою, зроблю ін'єкцію і заберу ту рідину, якби відкачаю, так сказати, і потім зроблю такий бандаж, щоб дуже прижав ту шкіру, щоб воно знову та рідина не набралась. Так що, якби step one, я би сказала, залишити, подивитися, може рідина і не набереться. Step two, якщо воно справді набирається, воно інколи може бути дискомфорт для пацієнта, то я би тоді зробила aspiration, щоб забрати ту рідину, і хіба що, якщо воно справді дуже багато рідини, то тоді, може, потрібно назад поставити дренаж, але не завжди потрібно, так що якби така більше клінічний асесмент, чи справді там багато є тої рідини, чи ні.
Супер, дякую за запитання. Вибачайте, але тільки по одному запитанні сьогодні. Решту готуйте для доктор Каранець в нашому додатку. Я беру на себе допомогу з реєстрацією. Тому, так, я думаю, що це останнє питання з піднятих рук. Доктор Ноздрін, Маркіян, ваше запитання?
Дякую ще раз за дуже чудову лекцію. Скажіть, будь ласка, коли ви робите фрі-флеп, чи використовуєте ви якісь судинно-розширюючі засоби на ніжку судинну? І чи використовуєте рутинно, або чи взагалі використовуєте ВАК-терапію при операціях фрі-флеп?
Значить, на рахунок фрі-флеп, коли ми зшиваємо артерії, вени, ми використовуємо такі розріджені гепаринові препарати, щоб якби ними промити артерію, вену перед тим, ніж як ми робимо анестезіс. Часто так само ми навіть через вену, через IV дамо гепаринове, щоб знову ж все було розріджено, щоб кров, щоб не робився blood clot. Часто також після великих фрі-флепів ми просто ми ставимо пацієнта на аспірин 81 мг, наприклад, на протязі 2 тижнів раз в день, щоб ніби все це допомогло, щоб розрядити, щоб кров була розріджена, щоб циркуляція була хороша. І пацієнт може з тим аспірином потім додому йти. Так? На рахунок ваків, в нас це дуже поширено. Під час фрі-флепів ми ставимо вак, хіба що якщо ми не можемо справді зашити той донор сайт. Наприклад, інколи, якщо ми беремо там шкіру з ноги і потім робимо, ми часто практикуємо, до речі, ваки як болстери, для того, щоб вільний клапан прижився. Так що, наприклад, якщо я роблю free-flap з ноги і роблю на то місце ставлю skin graft, то я поставлю, тоді пришию skin graft, але поставлю вак як болстер, і знову ж таки мінімум 5-7 днів, і, якщо чесно, найкращі клапани приживаються з ваками, так що в нас вак дуже практикується для прижиття вільних клапанів. Ну, donor site. Звичайно, там, де мікрохірургія, ми ніколи не хочемо ставити ніякі ваки, ніякі pressure, але для вільних клаптів, для великих дефектів, для skin graftів, так, практикуємо.
Дякую дуже.
Супер, дякую за запитання і відповідь. In the last one question з нашого чату. How do you manage donor site in skin grafts?
Ну так, я думаю, що це питання, мабуть, на рахунок split thickness skin graft, бо знову, якщо ми беремо вільний клапан і зашиваємо, бо це маленький skin graft, всі можуть зашити, так? А якщо це є велика рана, і ми беремо дерматомом, то є split thickness skin graft, в основному перший етап ми заклеюємо той donor site такою прозрачною наклейкою, і воно допомагає epithelialization, щоб ніби шкірні клітини починали заживати. І якщо в основному я це саме зроблю, і перший тиждень я просто залишаю той донор сайт під такою великою прозрачною наклейкою, і ці клітини починають, шкірні клітини, наростати. Потім через тиждень я знімаю цю прозрачну наклейку і починаю доступ до повітря, щоб тепер воно підсихало, airing out. І я кажу пацієнтам, що вони якомога більше, хоча це якби рана, яка загоюється, але потрібно, щоб воно підсихало, бо якщо воно весь час буде прикрите, воно буде дуже довго заживати. Тому після перших 70 днів ми відкриваємо цей donor site і починаємо air out. І хіба ж якщо пацієнт кудись мусить вийти, то тоді прикривається. але чимось таким non-sticky. Бо ми не хочемо, щоб кожен раз був бандаж і знімалися ці клітини шкірні, котрі починають наростати. І важливо сказати пацієнтам, що це також може зайняти 2 місяці інколи, щоб воно це все зажило. Бо це якби велике abrasion. Але є різні люди роблять по-різному, але я практикую так, і з мого досвіду воно допомагає, щоб це добре заживало. І потім вже, як шкіра підсохне, наприклад, ми говоримо на нозі, так, якщо ми взяли великий split-thickness skin graft, тепер шкіра підсихає, потім я починаю просто казати, що пацієнт мазав раз в день вазеліном, щоб та шкіра більше була зволожена і заживала ще краще. Так що так поступово, перший тиждень повністю прикритий, потім починаємо доступ повітря, і потім вже як воно підсохне, тоді вазелінове просто раз в день мажемо.
Супер, вичерпна відповідь, дякую дуже. Я думаю, що на сьогодні будемо закінчувати.
Так,
Дякую.
біжу до пацієнтів.
Дякую дуже, доктор Каранець, що ви погодилися до нас долучитись до нашого курсу, підготували таку чудову презентацію.
Вибачайте за technical difficulties.
Я бачу усмішки на обличчях, тому думаю, це нікому не зашкодило. І така велика кількість піднятих рук і запитань. Думаю, це малі дрібниці, які тільки свідчать про те, що ми всі люди, і всіх нас якби однакові бувають проблеми. І я запрошую ще раз всіх доєднуватись до Heal.ua. Я дуже щиро запрошую доктор Каранець до нас долучатись. Там
Я вже підписана є, так, я є. Але я просто, як ми зробимо, бо мені здається, це добре мати такий якби віртуальний доступ. Я напишу тут в чаті свій імейл, так що якщо ви маєте якісь питання, ви можете завжди до мене написати імейл, чи навіть фотографію вислати, якщо якесь питання. Навіть якщо я зразу не відповім, я до того дойду так само, бо в мене багато пацієнтів, але я рада з нашими... Мені, якщо чесно, дуже приємно, що є стільки молодих українських спеціалістів, хірургів, лікарів, які хочуть вчитися і краще щось знати, і поправляти свою практику. Я весь час щось поновлюю, підправляю, так що це все ми всі люди, ми всі хочемо якнайкраще, але мене найбільше вразило, як я була на Україні минулого року, те, наскільки молоді лікарі, в них таке було бажання, і скільки до нас приїхало, так само було на наш симпозіум, і всі хотіли щось навчитись, і мені здається, що це просто amazing, що ви це робите, ви це вечором сидите, і для мене це дуже приємно це бачити і ділитися з вами. І знову ж таки, якщо я можу допомогти віртуально з вашими пацієнтами, навіть відписати свою opinion, думку, я з радістю це зроблю і допоможу.
Немає що додати. Дякую дуже.
Окей, добре, я побігла до пацієнтів, на добраніч.
Дуже дякую.
Слава Україні!
Дякую.
Героям слава.
Щасливо.
Героям слава.